So we're going to be starting our plenary orals very shortly, and we have 4 fantastic presenters.
So we thought maybe we could sit up here, and that'll cut time.
That's fantastic. Could I ask the presenters to come up to the front? We happen to have 4 chairs. So I need Clare is on her way, Tara, Jennifer, and Jonathan. If you could join us at the front, that would be fantastic. That'll shorten your walking distance to to come give your talk. So
we have a little sleep here. How are you? I'm on sabbatical, but this is my yeah. This was the one meeting I wanted.
okay, we're going to get started. So Tara and Jennifer, if you could join us at the front, that would be wherever you are. That would be fantastic. So just to come up and have a seat. And it's so again, we're going to have the format now is we're going to have 4 presentations. Each presentation is 10 minutes long, very much like we're going to have in the breakout groups later. So 10-minute presentation, these are very short, and 5 minutes for questions. If a speaker uses more than their 10 minutes to present, I will give you a signal at the 15-minute mark, and then you won't have time for questions. So that's kind of how it works. You have the 15 minutes to use as you would like. And I think we're just looking for Tara to join us at the front. Fantastic. And then we will get underway. Excellent. So it's my great pleasure to introduce our first speaker. Our first speaker is Dr. Clare Liddy. Clare is the professor in family medicine at the University of Ottawa. She's also the chair of family medicine on sabbatical right now. And Bill Hogg is here filling in in that role. Clare is also a pioneer, and among the many things that she's done is to lead and co-lead a program called eConsult that many of us rely on and use every single day, and that has spread across Canada, and I would think around the world as well, from what I've heard. And I know it's one of the examples that we use at CHR of where did research make a difference. And we use this all the time, Clare. So over to you.
Thank you so much. So it's great to be here with you. So I'm Clare, and I'm a family doctor. I am a primary care provider. And one of the big messages is that what I saw and how we ended up, and I'm going to give this 15-year snapshot in 10 minutes, but it all started with a problem. So just if you take one thing away, think about what are the problems that you face in terms of the work that you're doing in healthcare. My disclosures, the big one is I have never ever received any money from any commercial interest, so I sort of like to point that out, even though this is, and it did end up being a digital project, and you can see my other affiliations. I'm here on behalf of a really large team, so the second message takeaway is that I did not do this alone. I co-created it. A shout out to Dr. Aaron Keeley and Mr. Amir Afkam. They're pictured up on the right with the flowers. Alongside of me, and then also many other people have made up the team. And so when you have a problem, I think the problem could be a problem that many other people have, and then if you want to tackle it, you definitely need to engage a very large team of people. We did and have been generously supported, shout out to Inspire PHC and also Applied Health Research Questions under this program, plus other funders, CIHR, et cetera. But there were a lot of people who early on took a risk on us, and that's one of the things that, again, we had a lot of passion, and it was a big problem. So what is the problem? This is actually a problem of accessing specialist care. When I was a family doctor in a clinic, I referred a patient to my colleague, Dr. Keeley, many years ago, 2009, and she's an endocrinologist. And I had done my work with the patient in terms of what they had and what the complexities were, and we needed that specialist advice. They triaged it, which is great, and then I was asked as the family doctor to phone the patient and let them know that they would have the appointment. It's very important. It'll be in 9 months. And that really was the straw that broke the camel's back in terms of, for me, as a researcher and a clinician. This is not a unique problem, and as Rick alluded to, like it's all over many other countries. But you know, Canada in this Commonwealth survey, if you ask people what's the percentage and how often are you waiting, or how many people are waiting longer than 4 weeks to get their non-urgent specialist appointment, we are at the bottom of the list and still sitting, I think it's in the 65% of people will say, yes, I have waited 4 weeks or longer to see a specialist. So a big problem, what can we do about it? And I had no idea about anything digital, was not thinking about that. We looked and had a chat with my colleague, Dr. Keeley. We put in a small grant. It was actually on the premise of communication, and it was eConsult. We called it eConsult then, and it was the idea that, well, look, maybe I just need to be able to have a conversation with you. I don't like phoning you because you're never available, or maybe I'm busy. Could we do something asynchronous? And at that time, we actually wrote the grant on the idea of using email. Lo and behold, we got the grant and then found out that the policies in terms of email of transmission of patient health information was very frowned upon. In fact, you know, put the big stop. And so then we had to go out and ask, and we asked a variety of partners and health regions, you know, do you have like a digital system that we could use for free, that we could do some form development to try to create this eConsult service? So that's really where it all began. And this is the workflow. Who's used eConsult or maybe had an eConsult? Okay, so about half the room. Yeah, it's really, like, it's very, very simple. And it's based on essentially, you're with me, I'm thinking, we need to refer, you need to see a cardiologist, here's an abnormality, not sure what to do with it. And instead of referring you for a face-to-face visit right away, I'm just going to go online. It's very secure, it meets all of the requirements, and I'm gonna send that question, but it's about you. It's about you as the patient. And I'm gonna ask that specialist, and I don't need to know who the specialist is when I initiate. It can be a specialty group. So I'm sending it to cardiology, and then I'm asking them, could you answer me in a week? So that seemed really reasonable. It's not urgent. These are not for urgent. And then I'm gonna attach the lab, or the EKG in this case, or maybe it was a result, and then I'm gonna have that conversation. So eConsult, and we did it. The early work that we did, essentially, we did a lot of research, and I'll show you snapshot. I have more information you can look online, but one of the biggest things was, is this acceptable to patients, right? We're saying, maybe you're not gonna go and have that face-to-face visit right away. You'd be waiting months anyways, but let's see if you would like this, and because I'm gonna get the result back, and then I will share it with you. Oh, the dermatologist said, yes, this is a bump, we need to do a biopsy, we're gonna do it, and then we're gonna have the conversation again on an ongoing basis. So the patient acceptability in the early years, this was one of our first studies, was very positive. And people were really delighted. These are some of their, in their own words, and you can see the paper if you'd like all the detail, but a really nice study that just reassured us again that we were on the right track. So getting onto the right track, for all of you who are trying to recruit practices or family doctors, primary care providers to be in your study, please look at the graph on the left. So that is the trickle. So from 2009, when we got funded, to 2011, it took us basically that amount of time to get, and those numbers are the number of family doctors who signed up to, we have 4 who've signed up now to work with us on this study for eConsult. 18 who have signed up. So it takes a long time, and we were just trying to, we had 5 services available then, and we were trying to get 50 eConsults in our system so we could do that initial evaluation that this actually worked, that the message gets to where you need to get to. We did the qualitative, doing the patient surveys, et cetera. But it takes a long time. It took me a long time, and you just need to be persistent and keep going, because the graph on the right and where we're at right now, and what Rick was saying, is that we turned this research project, this little idea that we had a problem, came up with a solution, and then did the research due diligence into what has become a provincial program funded by the Ontario Ministry of Health and Ontario Health. So the numbers that you see on this one are how many people have had, or how many eConsults have been processed in the last year. So almost 125,000. So recall 2010, we were trying to have 50, and now at the program level, which was implemented fully in 2018, there's 125,000 almost eConsults that have gone through. Now, the service quality, we monitor it, so you still get that response in a median of a day, even though we now have over 150 specialty groups, so we've done a lot of engagement. And any primary care provider who does referrals, so nurse practitioners, family doctors, can basically freely access the system. It's all funded through the government. On the right, what you see is a snapshot of who are we sending these eConsults to. These are the top specialty groups. And you have endocrinology. Dr. Keeley likes to shout that that one is always up there. Dermatology is the most popular because it's easy, especially nowadays, to use the smartphone and do the images. And then you can see, though, that there's also complex cases, and we have psychiatry available, anything that you can think of. We have chronic pain, palliative care, a couple of posters on that, and we're looking at dementia. So this is I think, a real success story, and this is the impact in terms of being able to get that access. And imagine 1 day response versus 9 months before you even walk in the door for that appointment. Of course, if you still need to have the face-to-face referral, you go ahead with it, and we have been looking at that. But what is the interesting thing, and this gives a snapshot of the evaluation that we've been doing. It was started on triple aim, then it went to quadruple aim, and we do actually have the quintuple aim now with an equity lens. But this goes across the 4 dimensions, and what is the impact of eConsult? So on better population health, it really is improving access to that specialist advice. It is having huge impact. It's very positive results that we're getting. It's very quick. We also know that on a population level, that there's probably, we've marked about a 6% reduction in overall referrals, and that's because in 2/3 of the eConsult cases, the answer that you get, that you then communicate in whatever action you do with your patient, actually leads to you don't need to have your referral, so it obviates the need for that face-to-face referral at that time. We know that patients find it highly acceptable. We've done a lot of work with patient partners and co-design, and we have all sorts of materials in terms of talking to people. You have to consent to it, obviously. This is okay. To have an eConsult, people are very happy with it. It is lower cost than a traditional face-to-face referral. We've got 5 studies on that where we've looked at all sorts of different aspects on the costs of it. And also the improved provider experience. So both primary care providers and the specialists are highly positive and really like this. And, I was at a dinner last night, and family doctor said this is, again, transformative. It's so helpful in my practice. So that feels really good. So we've done a lot of work, and we've spread this, and I'm going to use the word model. So we've spread this model across Canada, and the highlight on here is all of the different areas and provinces that we have worked with, and many of them, or most of them, are using a different technology platform. So again, the model, which I'll just review again in a minute, it's about a model of care that can then be rolled out and implemented on whatever technology you have in your health system. Assuming it is secure, it can do the communication, you can set it up in terms of the groups, and again, get a timely response. So these are the key components of the base model, as we call it. And again, it's about trying to get that access to specialist advice. So we have set up specialty groups. I called it sort of my Noah's Ark. All I needed were 2 cardiologists. I just needed 2 endocrinologists, 2 psychiatrists to get it going. And then as soon as you initiate the eConsult, you get the name of who it is. And now it's so big that you can also do an individual specialist request if you have somebody who you would like to be doing an eConsult to. But the concept is that it's a group that you can access. We have really built it up, and we do a lot of, we don't do quality control on what the response is, but we do quality control in terms of if there's any complaints about, this wasn't like, it was a bit, short with me, and we're very interested in making sure that there's a lot of respect. Am I coming up on 15 minutes? I think, okay, sorry. Yeah, I know. I was thinking it was going down to 10. Sorry about that. I can talk a lot about eConsult. But it's managed. If you have a technical problem, we have a small team that provides the support super quickly. We built in evaluation and quality along the way, and that's one of the ways that we've done all of the research. It just is a very automatic survey that you did for about 10 years actually on this service in eConsult. So key lessons learned, how did we do this? Again, partnerships. We engage stakeholders. So I did get involved in policy early on because realized that those were going to be a barrier. It's a new model of care. And then we also disseminated our information in a lot of different formats. So I'm going to just give you a snapshot of this. And we realized that, nobody actually, or a lot of people don't read the articles, and even if you send the abstracts. So we started to do infographics, videos. We'd created a lot of patient-facing materials. I've done an ebook, doing an ebook 2.0 now. We tried Facebook for a while, so all of these different ways of basically getting the key message out. And I think that's one of the ways, once we had good data and we were confident that this model needs to be rolled out across Ontario and, hey, you should think about using it elsewhere, then we tried to really do a lot of work simplifying how we communicate that information. So it is spread across Ontario, funded across many provinces in Canada, and the future direction, and we are already doing work and have implemented in Australia. I have a Brazilian family doctor who's did their PhD on this, and we're working with many other partners. So these are sort of the three areas that I envision we're going to go next. International spread. We're trying to link to the ICS data set, link the eConsult, lots of challenges there, so hopefully we can overcome that, and continuing to do a lot of knowledge mobilization as well as team building. Thank you.
Thank you very much, Claire. We have time for one really quick question and really quick response, if anyone has one, or if there's something online, Elliot.
And go to the QR code, because it gives you our patient.
Nothing online.
Check out the QR code. It gives a nice little video.
Okie doke. Well, you've said it all, Claire. Thank you so much. It's my great pleasure to introduce our next speaker, Dr. Tara Kiran. Tara is a very close clinical and research colleague of mine, and she's the Fidani Chair in Improvement and Innovation and Vice Chair of Quality Improvement in the Department of Family and Community Medicine at the University of Toronto. She's going to talk about, do physicians in family health teams roster more patients than physicians in non-team models? And a really good question.
Is it okay if I use this mic? Perfect. Can anybody hear me? Yeah? You can hear me? Perfect. This way I can see my own slides better. I love that the theme today is optimism. So yeah, go Jays, go. They're going to win today. But of course, it's optimism grounded in realism and data, as we talked about, and that's what I'm hoping to present with you today. Just to say that the work that I'm presenting today is part of actually a much larger body of work that was contracted by Ontario Health to a number of partners, including the Centre for Effective Practice, the Upstream Lab, and Accenture. And so this is just one small part of that work that was looking to evaluate team-based care in Ontario. Kudos to my wonderful team that all help support. So I think Lisa is here, of course, Rick, Hina, Elliot, Andrew, Sharir. I think I saw Marissa, Angelica from CEP, Isabella, Miriam. So lots of people here who've really helped with this work that I'm about to present. So Jane Philpott started the day really talking about this issue of people not having enough, not having the access to primary care that they need. So we know that there are somewhere between 5 to 6.5 million people across Canada that don't have access, and part of the challenge is the workforce. We just don't have enough family doctors. A federal report said that we're 23,000 family doctors short right now, not even considering that there's going to be retirements and that we have an aging population. So if you're interested in some of those workforce issues, I chat with my colleague, Dr. Ruth Laverne, on my new podcast, Primary Focus, so check it out. This was our first episode of season 2, and we really try and do a deep dive as to why do we have this doctor shortage and how it's affecting primary care, but also what we can do about it. And when we think about what is it that we can do about it, I think one of the things we talked about this morning is, the answer potentially is in teams. And I think Dr. Tom Bodenheimer from the US, he really lays it out very well in this article that was published a couple of years ago in the Annals of Family Medicine. It's titled Hope for the Future. And it really talks about this idea that teams are hope for the future. It's the potential for a clinician to be able to serve more people because of the expertise of a team. And so that's really the premise with which we're doing this research today is, we have teams in Ontario. Do we see that the teams in Ontario today, the way they're structured or have been structured over the last 15, 20 years, are they able to actually deliver on that hope of being able to have a physician care for more patients in that setting? And so we asked the question around what are the differences in roster sizes between team and non-team models. And the data I'm going to present today is really going to compare 3 groups. There's the family health team, which is mostly in the blue in the presentation. And then there's the capitation models. So that is physicians who are working, who are getting paid actually in the same way as in a family health team. In a family health team, those physicians are in an organization, a family health organization, and then they have another organization, a family health team that they're supposed to work together with. In a capitation model, it's just the family health organization, so the physicians are working, getting paid in the same way, but there's no team. And then there's the third model, the enhanced fee-for-service model, or many of you know the family health group, where most of the payment is actually fee-for-service, and again, there's no team. So we did this work using data from ICES, and I'm going to show you analysis that really is based in the year 2024. You'll see that we attach patients to these models both by formal rostering as well as virtual rostering, and happy to answer questions about that. I will say one of the weaknesses, so one important thing is we know that roster size might really differ by rurality, and so we do stratify by rurality. And then the other piece that's important to note is we don't have actual FTE numbers at ICES, so how many hours a week is a physician working. So we have to use a proxy for that, and we use the CHI definition, which is largely based on payment. So this is a weakness in our study, but we'll talk about how we try to address that weakness. Largely, we try to limit it to those with FTE 1 or more in some of our analysis. So I'm going to talk to you about some variations. We're going to compare the models, and then we're going to look at some stratified analysis, and then we're going to look at some stratified analysis that's adjusted. So what did we find? So just very quickly, we know that about 22% of residents in Ontario belong to a family health team. They're either virtually rostered or formally rostered to a family health team as of 2024. There were really substantial differences in both the physician and the patient characteristics among these 3 groups that we're comparing, and that's really important to keep in mind. So I'm not going to go through all of them, but just to say, for example, that family health teams are more rural and enhanced fee-for-service models are more urban. Comorbidity was higher in enhanced fee-for-service and lower in family health teams. There were more female physicians in family health teams and much fewer in enhanced fee-for-service. And again, physicians in enhanced fee-for-service models were much higher, which are older than, in general, the physicians in family health team models. So this slide is a bit hard to digest visually, but what it shows is the variation in roster size within a team and between teams. And so what you can see is we're restricting here to physicians practicing in urban areas who we think are practicing with an FTE of 1 or more. And every dot would be like a physician practice. And what you can see is the physicians are lined up vertically together if they're in the same group. So Rick and I, we work in the same family health team, so we would be found on the same vertical line. And let's say my roster size is higher, I would be higher on that line, and Rick would be a little bit lower. Not to say that we do have that difference, but just theoretically, if we did. And then like the average would be like the black line there. And then, so as you can see, like the average roster size for all these teams, it differs. You can see the black line going across in a way that illustrates that. But what you can also see is that in any one team, there's a large range in the roster size for doctors. Now, what is behind that variation? I think that's something that we really need to unpack, but one theory is, is it related to complexity? So we used a score, an ICES, something that was developed that is a marker of complexity. And the bottom line is that we didn't, although it looks like there's maybe a bit of a relationship, it really doesn't explain much more than like 3% of the overall variation. So we can't really explain this variation based on complexity. So now looking at the actual differences by model, what you can see is like this is just the raw numbers. And this is for the whole population of Ontario. You can see that family health teams at just under 1,200 have a lower mean roster size than enhanced fee-for-service models at around 1,600. If you restrict to urban areas where physicians are working a 1.0 or more, you can still see that there's a difference. So in this case now, family health team, the roster size is about 1,400 on average, whereas the enhanced fee-for-service model, it's about 1,900. So next up, I'm going to just share with you the stratified analysis that is also adjusted. And in this next stratified analysis, we not only stratified by FTE and rurality, but actually also physician gender, because one of the biggest drivers of how big your roster is actually is the physician gender. And so this is actually just looking at male physicians. And what you can see, so in the blue is the unadjusted bar, and orange is the adjusted bar, and the comparison is the capitation. And then you can kind of see these error bars as well. And what you can see is that after adjustment, so that's that orange bar, there's really very little difference between the roster size in a family health team and a capitation model, or even an enhanced fee-for-service and a capitation model, especially if you take the error bars into account. And so we see a similar but slightly different story among female physicians. I'm not going to go into detail here, just in the interest of time. And I will say that these analyses that we actually also restricted to just looking at formally rostered patients, because we were trying to even the playing field as much as possible when we were doing these comparisons. So lots and lots of detail there. And I guess at the end of the day, though, we wanted to answer this question. And you'll see that I did phrase it in a specific way. So it's not that I can confidently say that, yes, the roster sizes in capitation non-team models are higher than family health teams, because I think there's just a lot of variation here. But I think one thing that you can say pretty confidently from all of these analyses is that physicians in family health teams generally are not rostering more patients than physicians in non-team models. I think we can be pretty confident from the data about that answer. Of course, lots of limitations. So we conducted a cross-sectional analysis, and what we've learned from a lot of work we've done with models is that a lot of the differences actually predate even entry into a model, and so we can't really get into that, and there's a lot of self-selection, and we can only control for so many things when we're doing this kind of analysis based on administrative data. Importantly, we don't have physician hours worked. And there's some issues, things like, we know that in some family health teams, the NP patients are actually not formally rostered, and that could lead to undercounting. I think that it's also really important to contextualize that it was never a really clear goal of family health teams for the team to be able to enhance the capacity of the physicians there. And in fact, so much of the reporting, and I can say this from firsthand experiences, as I was the board chair for a team for many years, and the reporting really is about the volumes of people that our other health professionals are seeing and the kinds of programs they're delivering, not how they're helping the team to grow the capacity to serve more people. There are also really important governance and accountability differences between the physicians and the other team members. And of course, there's other ways in which other health professionals in these teams are contributing. All this to say that I think the other important observation that I personally made, and I know a lot of you have too, is that when we have designed teams here in Ontario, unfortunately, it does seem like many of our other health professionals are providing additive care as opposed to substitutive care. And I think that leads to some of the findings that we're seeing today. So I do think that if we want this better future with teams, enhancing the capacity of the clinicians that they serve, enhancing the capacity of clinicians to serve more people, that we are going to need to rethink how we're doing team-based care. And I look forward to more discussions. I think that presentation following mine is going to actually get into that. So, and if you want a really cool example, I'll just say our latest episode of our podcast, we have like a cool example of a clinic in Calgary that has figured out how to make the team work so that physicians are able to roster more patients. So thank you, and here we go. Oh, sorry.
Thank you very much, Tara. We do have time for some questions, but I'm going to kick off with the first one, which is, we heard earlier today that team-based care is the major strategy for addressing our problem of having 2 million people unattached in Ontario, yet teams don't work to look after more patients. How do we square that circle?
Yeah, great question. I mean, we have discussed this data with, of course, the primary care action team, actually, I shouldn't say we have discussed it. We've provided it to them. And I think there's a couple of things. One is the move forward on teams. I think the objectives are a lot clearer for the new teams, that the team members are there to expand the capacity of clinicians to be able to serve more patients collectively, and I think Jane said that. But I think the really hard work that all of us have to do, and many of us are in teams, I should say, and I think the teams that have been built, there's going to be significant change management that's needed, I think, in our current teams. And I'm hopeful that there will also be clearer direction and accountabilities and reporting that aligns with that.
Yeah, thanks very much, Tara. I see in our own family health team, our nurse practitioners are now wildly enrolling patients and taking on new patients. And I think that's the provincial direction that we've all heard and that is working, actually, in our own setting, and I hope many other settings. We have time for maybe one more question. Yeah, please go ahead.
Yeah, hi, Steve Nastos. I work at the Ontario Medical Association. Thanks so much for this. This is great. Love the topic, love the data, love the research, really near and dear to my heart. I think your considerations and your conclusions are spot on. One question is, were you able to account for differences in family health teams? Like, they are vastly different, right? You have the communities in the north that don't have a robust team, and then you have downtown St. Mike's, which is very rich and has a lot of support. Were you able to account for some of the differences, or how big the teams are, or what resources they're given?
The bottom line is no. We stratified based on what I said. So we did stratify by rurality. So a team like St. Mike's would not be grouped by a team that's working in Northern Ontario, because we would expect roster sizes, for example, to be quite different for physicians who are working in rural and northern areas. So yeah, that's the one piece we did. We didn't look at but I will also say part of this is a data issue. Yep. So why is it that we don't have data on physicians' hours worked? We don't actually have data on the team components. So we couldn't actually adjust for like how many team members do you have. So we can't actually do that deep dive in this data to say, okay, the teams that are high performing, is there a difference between them?
Great, thank you. And I love the shirt.
Thanks very much, Tara. That's fantastic. So the message is, if you've seen one family health team, you've seen one family health team. And I think even more so for community health centers. They're very, very different from each other, which is the perfect segue to our next speaker. Dr. Jennifer Shuldiner is a health services scientist at Women's College Hospital and an assistant professor at the Institute of Health Policy Management and Evaluation at the University of Toronto. We're going to learn all about bright spots in interprofessional primary care, learning from high-performing teams to optimize access, attachment, and equity. We're all looking for the answers. So Jennifer, over to you.
Thanks so much, Rick. Good morning, everybody. As Rick said, my name is Jen. I'm a scientist at Women's College Hospital. And I'm really excited to be here today to talk a little bit about bright spots in primary care, learning from high-performing teams. And I'm going to talk a little bit about those newly expanded teams that Jane Philpott spoke about this morning, and what they're doing to increase access, attachment, and equity, and what we can learn from those that are doing a really good job. So just before I get started, this work is on behalf of a greater team. Some of them are here today, so thank you for giving me the privilege to present on behalf of everybody. So as everybody in this room is aware, we have a bit of a crisis. Now I heard we're not supposed to use the word crisis anymore, but we're trying to fix a primary care crisis in Canada. We have over 6 million individuals that don't have a primary care clinician, and even those that have a primary care clinician often aren't able to access them. We have growing patient complexity, increasing mental health needs. And Ontario is trying to fix that with expanding primary care teams with the ambitious goal of attaching every single individual. And what we wanted to learn in this work is to understand those that are expanding and are doing new things. What are they doing really well so we can spread and scale those lessons across the province? So we decided to study bright spots. Why study bright spots? We saw that there was early success stories. Some teams were already showing early success, more attachment, even though they were dealing with the same systemic issues that other teams were doing. And we thought this was a great learning opportunity to find out from what's what's happening on the ground, what we can learn, and how we could spread those stories. So we did an in-depth case study analysis. We studied 7 high-performing teams across Ontario, different models, different regions, and we went out and we visited them. We did observations, we did interviews, we reviewed documents, and then we analyzed that using the consolidated framework for implementation research, which allowed us to systemically understand what they were doing, what they were implementing, and what the outcomes were. We developed logic models for each case and then synthesized those into a greater logic model so we can understand what was happening across teams. So let's start off by saying, what did these expanded teams do? Many of them hired nurse practitioners, which were rostering patients. This was a first for many family health teams. They also hired more physicians to roster patients, and also they hired nurses and administrative staff to help with capacity. We saw many teams open up new patient access initiatives with same-day access and also unattached clinics. Teams also broadened their services with mental health services, memory clinics, and lung clinics in order to help with the services for their populations. And they also opened up unattached clinics for new babies. We saw more partnerships with nursing homes and also with home care and also community paramedics. Some of the strategies that these teams used was patient-centered intake. So they did staged onboarding to ensure that everyone, when they got attached, was able to receive comprehensive care from day one without overburdening the clinic. They also were made sure to recruit and to find the patients that needed them the most, those with high complex needs. We saw expanded roles and task sharing. For example, registered nurses taking on most of the chronic disease management, or medical office assistants that were leading the onboarding of new patients. We saw increasing of same-day access to help alleviate emergency room reliance and community integration. For example, one team was working with community paramedics, so the community paramedics could identify the patients that needed help the most, and then also help with homebound care in coordination with the clinic. And these teams were telling us about early outcomes that they were seeing. They were able to increase their attachments, increase their programs, and their community emergency rooms were telling them that they were seeing a reduction in emergency room visits. So to unpack what was driving success, we mapped each team's implementation journey using the CFIR. So we looked at each setting. We looked at the determinants, what was happening in the inner setting, the outer setting, the individuals in the team, and then mapped their implementation journey across the outcomes. We synthesized that across all teams. So now let's dive into some key areas. So one of the cross-cutting themes that we saw was leadership. These teams had leaders that were driven, had transparent, mission-focused, and they had frequent communication with their teams. They also were able to foster a collaborative, respectful team culture that retained staff and reduced burnout. They used their resources strategically. For example, hiring admin staff to free up clinician time or task shifting. And we also saw strategic partnerships where sites can leverage each other's resources and work together collaboratively. Of course, this work hasn't been easy, and the teams also told us about a lot of challenges that they were experiencing. They spoke about pay inequities, how they had to compete with hospital salaries, and they also talked about hiring competition, how with all the newly expanded teams, everybody was hiring at the same time, and the pressure that created. Teams also spoke about how they had to balance meeting unmet needs of their current patient rosters while also trying to increase attachment at the same time. Another important issue that came up is with the provincial focus on attachment numbers may conflict with the team's desire to attach those that are the most complex. And these complex patient populations may inhibit them from getting to those numbers that they're trying to reach. Teams also spoke about the uncertainty on how to maximize capacity and efficiency and workflows within their teams, and they were looking for guidance on that. As discussed, one of the strongest findings from this work was the critical role of leadership. Across all our bright spot slots, we saw how strong, innovative, and hands-on leaders drove progress, often navigating funding uncertainty and staffing shortages and pressures through creativity and persistence. But also raises a bigger question. Is this sustainable or scalable? How do you spread extraordinary individuals across a province? We need systems that nurture and sustain this kind of leadership province-wide. At the same time, we saw that true progress isn't only just about numbers, but also the importance of ensuring that we're equity-focused. Success can't only be about attaching the most number of patients, but we also need to make sure that we're attaching those that need care the most. So what can we take away? Some thoughts on some actionable insights for primary care transformation. As we look ahead, sustaining team-based primary care we think will depend on optimizing how teams work together, clarifying roles and scope of practice so that every team can contribute to the top of their ability, and this can reduce duplication and strengthen efficiency and help prevent burnout among teams. Second, the importance of strong and empowered leadership is essential. We need to equip leaders with the skills to champion innovation and build peer networks to help them share lessons with each other, challenges, and practical solutions across regions. Third, ensuring sustainability requires realistic timelines and stable staffing. Teams need time, resources, and competitive compensation to embed new ways of working without losing their momentum. And finally, we must reduce our over-reliance on most responsible clinicians, ensuring nurses, allied staff, and administrative roles are fully leveraged to deliver care. Together, we think these strategies can move us forward towards universal attachment, building on what's working and adapting to local context and supporting teams to thrive. Thank you.
Thanks very much, Jen. That's really fantastic. You've actually stuck exactly to your 10 minutes as well, so kudos. We do have time for questions, which is really great, either online or in the room. And I'm going to kick off. So the focus on leadership, I think, is really critical. We heard an example earlier today of inspired and driven leadership with Dr. Philpott. You've encountered some of those leaders in your travels. Who have those? So first of all, I will also say I'm an enormous fan of implementation research, so congratulations on doing that. Who are the leaders? Do they tend to be because a unique feature of interprofessional teams in Ontario is that we do have professional leadership in the form of executive directors, for example, in family health teams and community health centers. Who were the leaders? Did they tend to be the clinician leaders, the physician leaders, the executive directors, or did it vary?
Yeah, thanks. It definitely varied. A lot of the leaders that we're referring to in this presentation was about the executive leadership that really went above and beyond, looking for every single partnership they could do, every resource they could leverage, and really caring about their staff and their teams and going the extra mile. And we also saw clinical leadership as well that was filling those roles as well.
Yeah, we've tended to look in the system, for doctors to do everything, run the practice, pay the rent, hire the staff, and do all the work to organize. And having the professional leaders come in, professional managers and professional leaders, sounds like a really important key element to leverage. So we've got time for another question. Please go ahead and introduce yourself, please.
My name is Mir. I'm a PhD student at Queen's University, and our team is we recently finished a trial integrating physiotherapists in primary care, and I'm doing a process evaluation on that. Brilliant presentation. Just a quick question regarding the fact that you did a case study on high-performing primary care, team-based primary care or primary care teams. So did you find anything regarding the point of care, the first point of contact, whether the teams were changing the first point of contact and whether that had anything to do with the successes that they were seeing early on in the process. So, yeah.
Yeah, thanks for that question. That definitely did come up with making sure the teams were making sure that they just weren't attaching individuals but not being able to provide them care. So making sure that the first visit they come in, sometimes they would give them double appointments so they could really be onboarded properly, and making sure not to overburden the clinic and staging that onboarding process, because it is quite a process and takes up a lot of time.
Our last question goes to you, Brenda.
Hey,
Can
Jen.
you introduce yourself,
Brenda,
please?
patient partner, patient disruptor for good within the healthcare system. Overall inquisitive and curious about health system transformation and change. I want you to talk about the role of the patient in leadership. I don't see myself as a leader, I really do not. But I really feel when you're building something top down, at some point it has to be ground up and get across the road in the middle. Can you just talk about that for a second?
Yeah, thanks for bringing that up. Well, one thing that we did cover in these bright spots is we saw that in their boards, there always was community members that were there trying to give direction for the clinics. There was a lot of patient engagements and surveys, and a big emphasis on ensuring that they were meeting the community's needs.
Thanks very much, Jen. That's fantastic. It's my great pleasure to thank you. Our last speaker, standing only between us and lunch, but I promise you a fantastic and inspiring talk, because I'm familiar with Jonathan's work. So Dr. Jonathan Fitzsimon is the medical lead of Renfrew County Virtual Triage and Assessment Center. I believe that Dr. Philpott mentioned your model, and you had a chance to chat last night together as well. So Dr. Fitzsimon's going to be talking about hybrid primary care and approach to reverse the inverse care law. So I'm sure he's going to tell you what that is if you don't know.
Thank you, Rick. And I know times are tight on these presentations, but I'm going to take half a minute of my time to share a reflection with you. I went to medical school in 2002, and since then there have been many female colleagues who've played a big influence on my career development. They've been my teacher, my mentor, my clinical colleague, my co-investigator, my mucker, to use Jane's phrase from this morning. And it occurred to me that the three previous speakers have all played at least one of those roles in my career development. So Clare, Tara, Jen, I want to thank you for your generosity. Thank you for your inspiration. And it's a real privilege to be sharing the stage with you at this plenary session. Okay, 1971. Dr. Julian Tudor-Hart, a British GP, who worked in a rural community in South Wales, published a paper in The Lancet titled The Inverse Care Law. And he described how the availability of good medical care tends to vary inversely with the need for it in the population served. It became a seminal paper, and he became internationally renowned as one of the first to integrate clinical care with epidemiological research, ultimately serving as a model for community-based healthcare. Fast forward 54 years. 18% of Canadians live in rural communities, yet only 8% of physicians practice in those areas. Canada spends just over 5% of its healthcare budget on primary care, compared to an OECD average of over 8% and up to 10% in some of the highest performing systems. Yet around half of healthcare contacts in Ontario each day are within primary care. And there is a deep and long-standing evidence base describing the role of primary care preventing illness and death, and how those without access to primary care have worse health and higher rates of preventable disease. In European and Scandinavian research, the concept of unattachment barely exists. When a physician retires, patients simply transfer, ideally within the same clinic, sometimes to a different clinic. Continuity research in the European context asks about which clinic, not whether there was a clinic at all. In January, we published a scoping review on the impact of change in primary care attachment. And of the 31 studies included in the review, only 2 looked at the impact of unattachment duration, both studies from Canada. I work in Renfrew County, Ontario's largest geographic county, has a population that's older, poorer, has higher rates of chronic disease than the provincial averages, and historically has had some of the highest rates of unattachment in Ontario. Now, for many years, there have been fully salaried and blended salaried model for physicians in these communities. These come with pension and health benefits, paid vacation, and the infrastructure of a family health team. Yet many of these positions went unfilled because of an inability to recruit doctors to physically relocate to these rural communities. So we should reflect on not just the breadth, but also the depth of the unattachment problem in many rural communities. In March, we published a study showing that over a quarter of the unattached residents in Renfrew County had spent 15 years or longer without primary care, more than double the level across Ontario. We demonstrated how unattachment combined with multimorbidity is exponentially more impactful. Multimorbid, unattached patients have annual total healthcare costs almost $8,000 per person higher than attached patients without chronic disease. We recently completed a study, it's currently in peer review, showing an association with all-cause mortality up to 12 times higher for unattached patients with high levels of chronic disease compared to attached patients without chronic disease, and similar double-digit odds ratios for hospitalization rates. The people who need the most help are not getting the type of care they need. The inverse care law continues to exert its influence. I believe there's a way forward. In Renfrew County, we've developed, implemented, and evolved an award-winning hybrid approach to primary care. We blend in-person care with virtual care in order to deliver more equitable access to primary care in underserved communities. So when the COVID pandemic hit in 2020, Renfrew County was faced with the potential crisis of thousands of unattached residents overwhelming our community hospitals and emergency departments and putting many vulnerable residents at even greater risk. We created the Virtual Triage and Assessment Centre, or VTAC. Same or next day access to a phone or video appointment with a family doctor, with local support from community paramedics and a small number of family doctors for in-person assessment and care. We've been able to recruit family doctors from all across Ontario to provide care to the underserved residents of rural communities. We've published several papers demonstrating the successful clinical and economic impact of VTAC, as well as the overwhelmingly positive experiences of VTAC's patients and doctors. In 2021, we took the hybrid approach to a new level, integrated virtual care, or IVC. We used those unfilled, salaried family doctor positions to employ doctors working remotely, but formally attach some of the unattached users of VTAC living in that community. The doctor provides care through a range of virtual options, so secure messaging, telephone, video and enhanced video encounters. That's where a medical office assistant or nurse is in the room with the doctor on video real time. There are some doctors and nurse practitioners based in the local clinics, not enough to attach everyone, but available as group colleagues to provide an in-person physical examination when it's required. All of the IHP services are available to the patients, and the administrative and IT structure of the family health team support the patients and the doctors. Almost 7,000 previously unattached residents are now attached to one of the 18 family doctors and receive comprehensive team-based primary care in this way. So this year we've published studies on the positive experience of patients, clinicians and non-clinical staff, and we've tracked and previously published dramatic increases in preventative care metrics. Now VTAC's evolving again, including what we call VTAC attachment. Last year alone, almost 400 people had 12 or more encounters with a VTAC doctor. Rather than having multiple one-off encounters with a different doctor each time, we're directing resources to these most vulnerable, highest need VTAC users to be formally attached to a named VTAC family doctor, using the hybrid approach to their care and carefully managing the workload on each doctor. Thanks to the commitment of the Ontario government and the work being done by Dr. Jane Philpott and the Primary Care Action Team, many of our local interprofessional primary care teams will receive new funding to facilitate their expansion. However, the target of universal attachment across Ontario by 2029 is still 4 years away, and as I've described, new funding alone hasn't always been able to solve the problem of recruitment to rural communities. With VTAC attachment and a hybrid approach, we can utilize existing family doctor capacity from across Ontario and perhaps with further intra-provincial licensing agreements, potentially from physicians across Canada. We already have some local doctors, nurse practitioners, and paramedics available to provide in-person care, and we're partnering with other local interprofessional primary care teams to make sure we have access to a wide range of local interprofessional healthcare providers. So VTAC has an 8 a.m. to 8 p.m., 7 days a week, same or next day access policy. That's for first contact. And now this will be combined with the comprehensiveness, continuity, and coordination principles of IVC. There are other benefits to a hybrid approach. Attaching large numbers of previously unattached patients, many with multiple pressing needs, as Jen said earlier, is a significant challenge. We've spent the last 2 years, with a lot of support from Healthcare Excellence Canada, fine-tuning our patient onboarding process and taking most of the administrative burden of onboarding patients away from the doctors. So as new doctors and nurse practitioners are recruited into the local communities, hopefully over the coming months and years, we'll also be able to offer a transfer option to VTAC-attached patients to move to a new locally based family doctor or nurse practitioner if they want to, but with their pressing needs having been addressed, prescriptions reviewed, routine tests, investigations, and preventative care up to date, and an accurate electronic medical record all ready to follow them. This approach shifts from serial episodic care encounters to offering attachment to the most vulnerable patients, the highest needs patients. And it does so without exposing newly qualified family doctors and nurse practitioners to an overwhelming clinical workload. That can lead to inevitable burnout and the unattachment cycle starting all over again. So our research has demonstrated that the hybrid approach is accepted and appreciated by patients, clinicians, and non-clinical staff. A hybrid approach can help to solve the historically insolvable problem to untie the Gordian knot, if you like, of providing care in underserved areas without relying entirely on the physical relocation of staff to those areas. So through flexible, creative, and innovative thinking, we can direct system capacity to flow now to those most in need, rather than having those most in need wait for system capacity to reach them. I believe a hybrid approach is a mechanism to reverse the inverse care law. Thank you.
Thank you so much, Jonathan. We actually do have, you're right on time. We have time for a few questions if people want to ask, or if there's anyone online who has a question. I am happy once again to kick off. I'm really inspired by this model of care, by the innovation, by the implementation, and by the results. How can this spread elsewhere across Ontario and across Canada? What sort of strategies do you think could be used to make this model generally available in the kinds of rural areas that you're working in? Because we have many of those areas.
So I think there are multiple strategies required. I think you're right, first of all, identifying the areas where it can work. I don't think it is restricted just to rural communities. when I started doing research 5 years ago, I used to talk about rural, remote, and underserved communities. I think the underserved captures many different types of communities now. And I think what we've been able to demonstrate is that pulling capacity where there is some spare capacity, and we have a whole range of people that offer up flexible working hours, working from home, so it opens up new capacity in the existing workforce. So I think it's just a process of bringing those two things together. Where are the communities that are struggling to recruit physically? And so where can we tap into the capacity where it's available and bring it together?
Thanks very much. I see Archana. Please go ahead, introduce yourself.
Hi, everyone. My name is Archana Gupta. I'm a family physician and a clinician scientist at St. Michael's Hospital and at Upstream Lab. Thank you so much, Jonathan, for the really fantastic presentation. I'm reflecting on the conversations we've been having this morning, and as we think about how do we implement change within structures that have existed for a long time, I'm curious to know more about the physicians who are practicing in these models as the virtual doctors. Like, are they new grads? Is this something that appeals to them? Do they work part-time locally and then do this part-time? Do they have the capacity to maintain their in-person skills alongside this? Like, how do we advertise this as a great way of being a part of comprehensive care?
Thank you. That's a great question. I don't know, is Judy Bell Brown in the audience? Hi, Judy. Another one of my teacher, mentor, incredible sort of contributors to my career. So I've been working with Judy. We have in peer review a paper where we actually interviewed all of the IVC doctors to try and find out what were the factors that influenced them, first of all, to join the program, and secondly, because there has been some turnover, so why did some leave, whereas others stayed and expanded their practice? And I think, when I reflect back, the CVs all look identical, so why is there some differences between them? And I think the short answer is there's huge variation. There are lots of reasons. So yes, we have new graduates, people who are perhaps figuring out where they want to live, what practice style they want to work in, but we also have people much later on in their career. So certainly in the VTAC program, we have semi-retired doctors, don't want to still have hospital roles, which come with rural communities, but do want to sort of contribute working in a part-time basis. We have very flexible, family-friendly hours. You can work from home, so it opens up capacity for a whole other group of physicians. So I think there's no one single answer, and we explore those in a paper which hopefully will be published soon.
We have a question online. Please go ahead, Elliot.
It's for you, Jonathan. So it's Ryan Doherty at Empower Health, and he said, to better understand how to support scale of VTAC attachment, how are you attaching the high-need patients? Is it an automated, digitally enabled process or a manual process?
So we can pull a report from, we have a single EMR for all of the patients' records, so we can pull a report to see who are the highest users of VTAC. That's our first phase. So people that had 12 or more appointments in the last year and had an appointment at least 8 of the 12 months. So it wasn't just a single acute issue where you had lots of appointments over a few weeks. So prolonged use of acute episodic care. We're also working with local colleagues to identify people who are using the emergency departments a lot, even though they might not be calling VTAC. And we're open to other ideas. So there's a geriatric daycare program in the county. Many of those patients aren't attached, and then they struggle to navigate the system. So there's multiple ways, which was a lesson we learned from the IVC program 4 years ago, multiple ways of identifying people how to come in.
The very last brief question and brief response goes to you, Anil. Please introduce you. Well, you were introduced earlier, but go ahead anyway.
All right. O'Neill Bhattacharya, family physician, clinician scientist. So thank you, Jonathan, for summarizing 5 years of work so succinctly. I'm curious around the niche for IVC. So if we were to, to Rick's question, expand it beyond that, how big is the areas that will not get an in-person family doc anytime soon? And so how big is that niche? And if you were to grow IVC, what corners would you have to cut to get to, attaching everyone who's in a region that will probably not get an in-person care physician in the next 5 years?
Let me start with the second bit first, perhaps some of the corners that we cut. So I shouldn't use the phrase cobbling together. That sounds like it's way less formal than it is. But we're trying to sort of bring in the IHPs that we think we're going to need most. So the team-based pharmacist, crucial in the onboarding process. The social worker, lots of mental health and addiction problems where we are. So the key elements of the team first, and then again to sort of like follow on from what Jane was saying this morning about kind of like evolving as we go. So maybe cutting a few corners with the whole scope of the team at first, and use the locally important things that are there. How do we identify like the capacity? I guess I don't know the answer because I've never pushed it that far. I do know as soon as I put an ad out for more doctors, I've got a wait list of family doctors. Half of the 45 doctors in our team want more hours. So there is definitely a capacity for growth. How far it goes, I'm not so sure.
I want to thank our speakers from this session. This was really inspiring, understanding innovations, the impact of innovations, how we understand implementation, how we understand where we are and the distance we need to go to the models of care and the types of care that we need to provide.
Can I just give one plug? I know that Jonathan's work is amazing, and I actually had a chance to go to the practice, and I just say that in 2 weeks we'll have an episode where you can go to the practice with us and meet the pharmacist and meet the patients and meet the clerical staff and really figure out how it works. So yes, tune into the podcast 2 weeks.
And I love Tara's podcast, and that's a really great plug. So we have reached lunchtime for everybody. So what's going to happen is we're going to move to lunch now. We're only a tiny bit behind time, and we started a little bit late as well. So I think we're not doing too badly. So lunch is going to be until 12:30. The poster session follows that. So many of you have posters. There's so much to share. There's so much to interact and talk to each other about, and the poster time is perfect to do that. Posters are on the mezzanine level in Willow East and the Willow Foyer. Following the poster sessions, there will be the concurrent oral sessions starting at 1:30. Those sessions, the oral sessions are divided between Dominion and Mezzanine, so there'll be additional minutes of transition. If you're unsure where to go, check at the desk. Check with Elliot, check with Lynn, check with the wonderful Queen's University and other staff that we have if you're unsure about navigation. So lunch till 12:30, posters till 1:30, concurrent orals till 2:30, then a coffee break, then back here at 2:45 till 4 for an amazing final and kind of closing plenary at that time. So enjoy your lunch, enjoy all the interaction that's going to happen in the next little while, and we'll see you around the place and then back here at 2:45.